Shall we start, sir?
Yes, you're ready, doctor?
Yes, sir. Hello,
Yes.
good evening.
Give me a minute, doctor. I'll start the timer.
Okay, sir.
Okay. Can you see the screen?
Yes, sir, I can see.
Okay, doctor. Fine. You can start, doctor.
Hello, Mrs. Muntas. This is Dr. Kranti Kiran, one of the medical doctors here. Uh, can I confirm your name and age, please?
I'm Mumtaz, doctor. I'm 24.
Okay. Thank you for confirming that. I will be asking you a few questions regarding your health condition, followed by
Mm-hmm.
explanation, and later
Okay.
addressing questions. Is that okay?
Yes.
Okay. Are you comfortable now?
Yes.
Okay. Please let me know. Please tell me, Muntas, what brings you here?
Doctor, I'm 24 now and I have got seizures.
Okay.
Okay. I have got seizures and I recently moved to UK and I wanted my prescription of carbamazepine. But in the
Okay.
pharmacy, they told me that they don't give me the prescription and it has to come from a doctor. And
Okay.
and I recently collapsed, and that's why I'm in the hospital. So I want to know the reason, and I need a prescription for my seizures.
Okay.
Yes, doctor, continue. You can take it straight.
Okay. Uh, your GP has given me a notes that was stating that you have complaints regarding some involuntary movements.
Yes, I get this shaking in my hands.
Okay, in your hands.
Get
Ne-
seizures.
Okay. 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 You are assuming that it is seizures.
Yes, I was told that I'm having seizures
By whom?
by the doctors,
Okay.
and they started me on this treatment.
Okay. And since when you have noticed this shaking of your hands?
I have got it since I was 14 years old, doctor.
Okay. Since then you were on this carbamazepine.
Yes.
Okay.
Initially, they started me on some different drug,
Okay.
something called as levetiracetam something, and it
Okay.
did not work fine on me, and then they started me on this drug.
Okay. Uh, when was the last episode of seizures you had?
I had it 2 weeks ago.
And did they find any reason for that? What is the trigger for that? Are you not compliant with medications?
I am taking my medications regularly.
Okay. So your seizure episodes were not properly controlled with this carbamazepine?
It is controlled, but I still keep getting few jerking, doctor.
Okay. So in the previous episodes of seizures, when you were previously not started on any treatment, did you suffer any loss of consciousness at the time of seizures?
What do you mean?
Losing your consciousness while you're having those shaking of hands?
Yes, I lose my consciousness.
Even now, 2 weeks ago you were saying that you suffered one episode of seizure. Even at that episode also you lost your consciousness.
Yes, I was kind of lost, I could sense that I'm gonna get seizures. Then I get this bit choking in my neck, then in my hands. Then I'm not myself. It is difficult to explain. My husband have witnessed few of my episodes.
During those episodes were you not responding to any stimulus from others?
I could hear my partner speaking to me, but I can't completely respond. I'm not myself when I get those episodes.
Okay, is there any loss of control over your bowels and bladders, bowel and waterworks
Once a doctor, when I was 18 years, I
uh,
wet my clothes.
during this episode, this
Yes,
kind of episode?
yes.
Okay. Okay. uh, Apart from these seizures, do you have any other medical illness or any surgical illness or any previous hospitalizations?
I just had an surgery for the appendix
Okay.
when I was 17.
Okay. And
That's all, doctor.
okay. Do you have any complaints now?
Like what, doctor?
Apart from this seizure or involuntary movements, do you have any other headache or vision problems?
Mm, there is no vision problem, but when I get seizures, my vision is a bit blurry.
Okay. Have you ever suffered any trauma because of falls because of the seizures?
No, I never hit anywhere.
So you are not completely losing your consciousness at the time of episode.
Like
You
I
are
told you,
just
doctor.
not
So,
responding.
I don't know what actually you're asking, but what I feel is I'm not myself when I get these episodes, and it's difficult for me to explain because I cannot respond to anything.
Okay. Is that involuntary movements start abruptly, or it will start at one part of the body and slowly it will extend and involve other body parts?
I get mostly in my hands.
Okay. Any issues with swallowing difficulty or any episodes of aspirations of food contents?
No, doctor.
Okay. So your seizure episode will start with a prodrome kind of thing, like you will be aware that you are about to have a seizure.
Yes, I'm
After
always aware. I'm always aware. I know that I'm gonna get this episode now.
and after the episode of seizure, how much time would it take for you to get back to normal?
After this, uh,
Hello, sir.
after this seizures, doctor, it can maybe for 15 minutes. Hello,
Yes,
hello.
sir. Yes, sir. It's good now,
Yeah.
sir. You can
So,
continue.
so after the seizures, doctor, I'm kind of confused. I'm maybe it takes me about 15 minutes or half an hour to be back to be my normal. Sometime if I get seizures during evening hours or night time, I just go to bed, and when I awake, I feel refreshed again. But yeah, but I feel a bit confused after the episodes.
Okay. Okay. Do you have any? How about your mood in general?
Mood in general is fine. I'm
Okay.
I'm always a bit a stress person, but I'm trying to manage that.
Okay. Stress. You're saying that you have a lot of stress with your life.
Not lot of stress, but it's a bit stressful. With the work and the family life.
Okay. And what about your behavior? Is there any change in your recent behavior?
No,
Any changes with your memory, speech, gait?
no problem with my memory.
Okay. And from okay, do you have any other family illness that runs in your family? Similar kind of seizure episodes?
No, doctor. Nobody has got any such jerking thing in my family.
Okay,
My
okay,
father had some, what I can remember is he had some bleeding in his brain.
okay,
That's all.
okay. Can I ask you a few personal questions, Mrs. Mumtaz?
Yes.
Do you smoke?
No, doctor, I don't smoke.
Do you
I used
consume
to
alcohol?
smoke before, but
Okay,
very, very rarely, like one or two sticks, maybe over the weekend. That I did for 2 to 3 years, then I stopped.
okay. And do you consume alcohol?
No, I don't.
And did you use any recreational drugs?
No, no, never.
Okay. I would like to consider that smoking in any form is not good for your health. I want you
Yeah,
to.
yeah, I totally agree with you, doctor. I don't smoke
Okay.
anymore. I told you. It was
Okay.
long back when I was in my 18s, 20s. I used to smoke. I don't smoke.
Okay. Okay. I appreciate that. Uh, what do you do for your living?
I'm a pharmacist.
Okay. Do you drive?
Yes.
Okay. I strictly advise you to refrain yourself at least temporarily from driving till the point you will be completely free from seizures for at least 2 to 3 years. Okay. It is good for you and for others also. And how about
Okay.
impact
Okay.
of having, okay, how about impact of
Doctor,
having
you
seizures?
have taken 10 minutes already.
Okay, sir.
Okay. So we'll stop here.
Okay,
We'll
sir.
stop here. Your time will be done. Okay. Examination, but I'll come to that later. Okay. Dr. Supriya, are you here?
Yes, sir.
Yes, Dr. Sri. If anything else you want to know, anything different you want to explore in the story of your patient, you can carry on.
Yes, sir. Mrs. Mumtaz, may I know, did you have any history of some jerking movements in your sleep if your partner has ever told you?
No, doctor, I have never jerked in my sleep.
Okay, this is a little sensitive, Mrs. Mumtaz, but may I know if you have any casual partners?
No.
Okay, it's only a stable partner, isn't it?
Yes.
Next, I would like to know are you married, right, Mumtaz? So I would like to know, do you use any contraception?
Yes.
Okay, and what form of contraception you use? Oral or
We use
intrauterine device?
we use this condoms, doctor,
All
so that
right.
I
You don't
don't get
use any
confused.
oral pills.
No.
You don't. Okay. All right. Fine. And are you considering pregnancy in the near future?
Doctor, what do I tell? I had a pregnancy. I was pregnant
Okay.
at the age of 19.
Okay.
I had a miscarriage.
All right. Is there any medical reason for that to happen, Mrs. Mumtaz?
Yes, they did not
And
warn me about this drug, this stupid drug that I take, this carbamazepine. They did not tell me that it can harm my baby, and I lost my baby, doctor, because of that.
okay, all right. Now I see it. I'm so sorry for you, Mrs. Mumtaz. I understand and I empathize with you. Uh, are you planning to have one sooner?
Yes, I want to, but I have been told that this medication, it would be difficult. I'm not sure if it is safe. That would be like my one more concern. If you can tell me if it is safe for us to start our family, it would be a great thing.
Okay, I'll be answering this question at the end of the session, Mrs. Mumtaz. Is that okay with you?
Okay.
And may I just confirm the last episode of Shaking was just 2 weeks ago, isn't it?
Yes, it was 2 weeks ago, doctor, last episode.
Okay, okay. I'll get back to answering this concern of yours at the end of the session. Is that okay with you?
Mm-hmm.
So just a few little questions. When you stand, if you have ever had this jerky movement, do you fall?
When I stand,
Yeah, suppose you have this jerky movements. Are you able to maintain your posture or do you fall?
yes, that's what, doctor. I know that I'm going to get this jerking. So what I do is I go and sit in the chair or just lie down because I fell once.
Okay,
Okay,
I
I fell
see.
once in the past, so I try to make sure that I don't hurt or injure myself. So I just go sit on a chair or just I lie down just to make sure I'm safe.
Okay, I understand. And Mrs. Mumtaz, could you please elaborate on how would you come to know that you're going to develop a seizure? What kind of feeling do you get? Sorry, jerky movements you're talking about.
Before jerky moments, I feel uneasy, doctor. It's difficult to explain. You anticipate things
Okay,
that
do you
that
get
that
any headaches or
I don't
or
get
something
headache.
abnormal?
I don't
Some
get
flashes of
headache.
light or anything?
No flashes of light. My vision go bit blurry.
Okay.
Yeah, and I feel some uneasiness.
Okay, all right. Has anybody witnessed you getting this jerky movements? And
Yes, my husband.
okay, and what does he tell about it?
He just tells me that I look so different, and
Did
he,
he
he
ever tell
gets
you
very,
that? Did
very,
you?
very worried.
Okay, I understand. Did he explain the movements in particular?
Yes.
The shaking of the hands or
In
any other
fact, in fact,
movements in
I know,
the.
doctor. In fact, few occasions, even I have seen my jerking in hands. Sometimes even my
Okay,
face go jerking.
okay, I understand. All right, and the jerking is not seen in any other part of the body, isn't it? Just the face
No,
and the
mostly
hands.
mostly in my face, in my hands, in my neck. I feel sometime. Okay, doctor, we'll
Okay.
we'll stop here. We'll give chance
Yes.
to someone else. Anybody else want to volunteer something? Any information? Anything else you want to get from here? So we already spent 15 minutes. Okay.
Yes,
Anybody? Who is
sorry.
it?
I'm Dr. Yatisham. I
Hello,
just
doctor.
wanted to, yeah, hi. I
Yes.
just
Go
wanted
on.
to ask if, yeah, I just wanted to ask this patient about any history related to liver disease, like yellowish discoloration of the eyes, any abdominal swelling, or so I just like to explore further for the uh, for liver disease.
Okay, there are no liver problems. And you asked abdominal swelling, is it?
Yes, abdominal distension,
Okay, no tummy discomfort or swelling, yes.
right? And I would also like to ask about any heart-related issues, any racing and pacing of the heart, any chest pain, any breathing difficulties.
No breathing difficulty. Racing of heartbeats on few occasions I have had, doctor.
Right, okay. And other than that, I would also like to check for, I mean, because they asked about a family history of fits. So I just want to ask generally if there's any other family history of note apart from the fits.
No, nothing. Everybody is fine in my family.
Right, okay. And yeah, I think that, so any uh, headache
No,
or visual problems
I told you I get some vision blurriness
only during the episodes?
only during the episode.
Right. And regarding those episodes where the patient had a fall, are they only during the episodes of jerky movements, or they are also they occur independently of the jerky movement as
Like
well?
what the falls?
Yes, these falls, they are also always
I felt twice, doctor, till now. Once when I was in my 90s, when I was 20, and now very recently, the last seizures, and that's why I'm in the hospital.
right, right. And since you have been diagnosed with these situations for that, have you been told about any specific diagnosis for that,
Yes,
or just a
they told me that I have got seizures.
all right, okay, right.
They
And
just told me that I have seizures. They tried some different medication in the beginning. It did not get corrected with that. Then they put me on this drug now, this carbamazepine. And but I still keep getting these episodes. So I don't know, doctor. It's very stressful and it's a very bad condition to have.
yeah,
I'm
I feel
totally fed up. And I don't get the prescription here in UK. When I go to the pharmacy, I give them a prescription from my country. And they don't give me the medication. That's horrible. They want me to get the prescription from you doctors. So if you can give me the prescription so that I can have a supply for an year, it would be very helpful. I can't go without
right.
medications. I'm scared. What if I get one more seizures and I fall and I hit my head?
Yeah, I fully appreciate. I think that that's a valid concern, and definitely we'll look into that. Uh, I just wanted to ask you a little bit more because you said that you have a history of one pregnancy loss, and some, your doctor told it could be due to the medication you were taking. Apart from that, have you got any other history of uh, abnormal clotting anywhere else, like any clot?
No,
Right. Uh, any skin rash or any lumps or bumps over your body?
no skin rashes.
Hmm. Right. So have you been on uh, the same dose of carbamazepine for the last how many years you have been on this medication without any change in the dosage?
Doctor, I'm on this carbamazepine. Initially, they started me on 100 milligrams. I used to
Hmm.
take it 2 times a day. Then they increased it to 200 milligrams for 2 times a day. And now currently I'm on 300 milligrams and I take it twice a day.
Right. And apart from that, have you been on any other medications?
No, just few multivitamin tablets.
Right. For how long you have been on these multivitamin tablets?
Just now and then, doctor, when I feel weak, tired.
Right. Have you been taking any over-the-counter medications?
No,
Any herbal medications?
no, doctor. We'll stop here. Anybody has got something else to ask? You can unmute and ask. Something which you think might not have been covered. Important to know what's going on with your patient.
Hello, sir.
Yes, doctor.
I'm Dr. Nozul, sir. I need to ask
Yes, yes,
almost
go
all
on.
question have been asked.
Okay.
So any history of What about your school performance? What was your school performance?
School, doctor, I did not go to school for a few years.
Why?
I was in Syria. There was a
Okay.
war when
Okay.
I was in my 14 years, and it was a very difficult phase with all the bombing that was going on around my city. My school was involved in that, and it got destroyed, and I could not go to my schools for a few years.
So, uh, so is there any skin changes?
No skill changes. There's no
No
problem with
skin
the
changes.
skin.
Any facial changes? Hello.
What is it, doctor? What did you ask?
So any facial
Hello.
changes? Color change in the face? Hello.
No facial changes. You are not audible, doctor. Okay. Right. Anyways, Dr. Kantikir.
Yes, sir.
Okay, doctor. So now you know the history, isn't it? Do you want to ask anything? So this is your case. So you have taken the history, and other candidates have helped you now, right?
Yes, sir. I
Okay.
just want to ask few questions regarding history if time is not an issue here.
Okay, time is not an issue. Go on. I just want the diagnosis in the end.
Okay,
You have
okay.
to tell me this is a real patient. This is a real history. I want you to tell what you're going to do with this patient in the end. That's all. Okay, right. Go on. What you want to ask?
So apart from this carbamazepine and other multivitamins, not on any other medications.
No, nothing.
Okay. How about bowel works and bladder works, sir?
Perfectly fine.
Okay.
No
No,
problem at all, doctor.
no recent rise in body temperature or
No,
no shortness of breath.
no,
Okay. Okay. Any weight changes, weather preference,
no weight changes.
joint pains, muscle
No
weakness,
weather preferences. No
joint,
joint pain.
no muscle weakness or soreness, stiffness.
No muscle weakness.
Okay, sir.
Okay, done.
Yes, yes, sir.
Okay, so all of you have taken 25 minutes till now for the history. I have given you enough time. You cannot complain. Okay, now, doctor, this is a history. So, what do you want to do in the examination in this patient? What all you want to examine? Suppose this case comes to you in your PACES exam. You get 5 minutes. You cannot get more than that. In fact, you will get less than 5 minutes time. A patient like this, where it is much more history predominant case, definitely will have 3 to 4 minutes, I believe, for the examination. What are the things you look for in this patient?
I'll cognition, mini mental score examination. Any
You will do a mini mental score examination in PACES. Do you have time?
uh,
Okay, whatever you think is relevant, you can tell me, doctor.
higher mental functions? I'll check, sir.
We'll check higher mental function test. Okay. How do you do that?
Obviously, she has given me the appropriate history itself.
Okay.
I ruled out higher mental functions.
Okay.
Um, any rigidity, power, reflex, planters, I'll check, sir, initially.
So you want to look for power. Okay, you want to look at the tone and reflexes. So a bit of neuro examination you want to
Yes.
do. Okay,
Yes, sir.
fine. Everything is normal. Next.
Mm,
Anything else you want to do?
CVS and RS also I want to check, sir, auscultated, because
CBS and RS, at least you will auscultate. Okay.
the
Fair enough.
respiratory is a bit high, 24, pulse is 60, borderline.
Yeah. Okay. Anything else you want to do in examination? After you might have done these two, you might still be having 1 more minute. Anything you want to do in this patient?
Slit lamp examination.
Slit lamp.
Okay. At least fundoscopy I'll check, sir.
Okay. Slit lamp you would do in PACES, doctor.
I'll offer.
Okay. Fundoscopy is something you can offer. Okay. What you want to look for in fundoscopy and why you want to do? Okay. So if you're offered fundoscopy, I think your 5 minutes would be done, doctor. Right. So these are the examination and all this examination is normal. Okay.
Okay, sir.
Sir, I would also want tongue biting marks.
Sorry.
Tongue biting marks.
No, there's no tongue biting marks in this patient. Okay, few of you are put here jaundice, pallor. No, the patient doesn't have any jaundice. The patient doesn't have any pallor. Okay, right, fine. So done, doctor. You are done with your history. You're done with your examination. I given you the findings, which is everything is normal. So now go on to patient concerns. You got 2 minutes.
Yes,
Doctor,
Mr.
doctor, will you give me the carbamazepine prescription today?
Yes, Mrs. Mumtaz, after talking to you and examining you,
Mhm.
to run few investigations.
Mhm.
Results are out. I'll be in a better position to let you know whether we can give you that prescription or not.
What?
For now, we'll
What?
continue
What?
the.
What? What investigation you wanna do? I have got seizures. I need to get this medication. They're already giving me this medication in the hospital, but I want to get the medication when I go home. I need them. I'll get seizures if I don't take.
Yes, yes. Abruptly, we are not going to stop that carbamazepine.
Yes. So
For
you'll give me the prescription, right? When I go home. You just told
uh,
me that you need to do some test.
yes, for now, we'll give you carbamazepine and let you be here till the
Okay.
investigations are done and the reports are out. And once
Okay.
the reports are out, we'll be in a better position to know.
I need my prescriptions, doctor.
Right now, I cannot give it. I'll give you directly the
But you will
medication.
assure me that when I go home, you'll give me, isn't it? That's all I
If
want to know. I cannot go home without the prescription. The
if the
pharmacist here doesn't give me the prescription, doesn't give me medications.
yes, at the time of discharge, we'll definitely give you that prescription.
Okay, okay. Thank you.
Uh,
Thanks for that.
okay. Do you have any other concerns?
And why this seizures doesn't stop? Why I still keep getting the seizures even after taking these medications?
Initially, I have to confirm whether it is a seizure or not. I doubt it could be a possibility of pseudo seizures here. Uh,
Sorry, what?
Pseudo seizures.
What is that?
It's a medical term that because of your stress, you might be having that kind of.
Because of my stress.
Yes, it is a possibility. But
It is because of my stress. What is the pseudo seizures? Do you mean I don't have seizures?
I'm not saying that you're not having seizures.
Doctors have put me on this medication at the age of 15. It's been 10 years I'm taking these medications, and now you're telling me I don't have seizures.
See,
I've
you.
shown to doctors in Syria. I have shown to the doctors in America. I have shown to the doctors in Australia, doctor. Everybody told me that I have seizures. And you're telling me I don't have seizures?
Okay, I if I sound that way, I'm so sorry for that. But I need to be quite
I
sure.
believe you just don't want me to give the prescription, and that's why you are saying this.
No, no, please. I'm so
Okay,
sorry.
your 2 minutes will be done, doctor, here now. Okay.
Okay.
Examiner's question. Okay, with this history and the examination findings, doctor, can you give me your differential diagnosis?
Sir, I have simple partial seizures, and I want to rule out pseudo seizures first in this case.
Anything else, doctor? Any other differential diagnosis?
Mm, he suffered loss of consciousness as well in few occasions. So, partial complex seizures could also be the possibility, sir.
Okay. Okay. Anybody else? Dr. Supriya, even you did the history taking, right? Any other differentials?
Actually, I would like to rule out possibility of, as he said, on his pseudo seizures, sir, or it could be other involuntary movements like a tremor or something like that, or just an anxiety, panic attack.
You think it is panic attacks? Okay. Okay. So you agree with the other differentials. You just want to add panic attacks to this.
Yes, sir.
Okay. Fine. Anybody else? Anybody else has a different diagnosis?
I would also think of breakthrough seizures.
So you think it is a breakthrough seizures, okay? That means she has seizures, isn't it? Not well controlled with the medications, okay? Anyone
I,
else?
I think
Hello,
that
sir.
this, yeah,
Hello.
I think that, sorry,
Yes, doctor, go on.
I think that this lady most likely has juvenile myoclonic epilepsy and she has been put on carbamazepine. So this most likely is not the right drug. So I think that's one of the reasons she's getting these recurrent episodes. So I think that my diagnosis most likely this lady has a juvenile myoclonic epilepsy.
Mm-hmm. Mm-hmm. Okay. Fine. Okay. I put it in your DDs. Yeah. Anything
Mesial
else?
of epilepsy.
Okay.
Doctor, can I comment?
Yes, doctor, you can comment.
If the patient he have tuberous sclerosis, if they receive carbamazepine, they exaggerated the epilepsy. I think we need to take more history because also there is family history of the brain bleeding. I think that
Okay. So what do you think? What is going on with the patient?
if the patient tuberous sclerosis,
So you think the
we
patient has
must
got tuberous sclerosis?
yes, they have history of the seizure, and if they give
Mm-hmm.
him carbamazepine,
Mm-hmm.
they
But there is
exaggerated the
no family
epilepsy.
history of seizures. How would you explain that?
He have family history of the intracranial bleeding. Am I right?
Mm-hmm. Mm-hmm.
We must take full history about family, and
Okay.
also we examine the
What
skin of
else
the
history you want
patient.
to take? You can take the history now. What else history you want to take
I,
in family?
I ask if there is any history of the epilepsy. I ask if there is any skin change, and also I ask. Uh, yes.
Okay, fine, doctor. Right. Good that you're thinking in terms of this conditions like tuberous sclerosis. Okay,
Hello,
somebody
sir.
commented that
Hello,
psychogenic non-epileptic seizures. Okay,
hello,
fine.
sir. Hello, sir.
Yes, yes, doctor.
So, can I put a differential?
Mm-hmm. Go on.
Okay, sir. So, as the patient is getting carbamazepine, there is a chance of breakthrough seizure with these drugs also, as because it can cause auto-induction.
Mm-hmm. Okay. So you meant drug induced.
Yes, sir.
Okay. Fine, fine. Good thought. Okay, fine. So we'll stop here. So all of you have put a nice thought in terms of what might be going on in this patient. Okay, so this is the exact history this patient had. Okay, this patient I saw in one of my first epilepsy clinic, and this was the first patient I saw. Okay, so I'll give you a exact history what happened. Okay, so at the age of 14, okay, when she was in Syria, okay, war started. That there's a lot of explosion and all that was happening, and at the age of 15 she started having seizures. Okay, she went to a local hospital in Syria where they did an EEG, they did an MRI, which was normal. Okay, EEG was normal. Okay, and they thought that she has got seizures, and she was started on Keppra, which is a levetiracetam. Did not get controlled with that. Okay, then she got married at the age of 18. Her husband was initially in USA. She went to the doctors in USA again because she was still getting these episodes. Again, EEG was done. Again, a repeat MRI was done, which was normal. Okay, EEG showed few abnormal epileptiform activities, but it was non-specific. They could not comment if it is due to seizures. That was the EEG finding, and the MRI was normal. Okay, and in USA they changed her drug from Keppra to carbamazepine. We don't know what diagnosis they thought, what type of seizures she presented at that time. We don't know that history. After that, when she was 22, okay, her husband moved to Australia. She was in Australia. She was still getting seizures. Again, an EEG was done. Again, an MRI was done, which was normal. Again, EEG showed the very similar findings what was found in USA. And the carbamazepine dose was escalated. She was put on 300 milligram twice a day. Okay. And then when she is 24, she presented to us in UK, recently moved to UK. She went to pharmacy and told them, give me the prescription, give me the carbamazepine. They did not give her this prescription. They told her, you cannot bring your Australia's prescription here and get the medications here. Go and get it from the NHS. Okay. She was about to be seen in the clinic. Then she had a collapse and she was in the hospital. Then she got discharged and she came to us in the clinic. This is the story of your patient. For how many years did this patient had seizures? 10 years, isn't it? 10 years. Now, let me tell you the suffering the patient had for this 10 years. 10 years of seizures. She had one loss of pregnancy, right? Which had a significant impact on her on her emotional well-being, significant impact on her family. So the husband was very supportive. Okay, and she had a significant side effects of this drug carbamazepine. She keeps getting hyponatremia. She keeps feeling dizzy. Okay, so this is the sufferings that our patient had, and she came with that. You will finally have some answer. Okay, when it comes to seizures, what history? None of you took a proper history regarding the seizures here. What is the proper history of the seizures? You should always tell your patients, look, I want to know everything about these seizures. What happens before you get seizures? What happens during the seizures? And what happens after the seizures? Okay, so you need to know all the three phases: pre-ictal, ictal, post-ictal. Okay, what are the questions? What all symptoms the patient will have pre-ictal? They might have sensory symptoms, right? They can have tingling, numbness, visual disturbances, which our patient had, isn't it? Visual disturbances. Sometimes they can have autonomic involvement in the form of palpitation, sweating, epigastric uprising sensation, feeling sick. None of you ask these questions here to this patient, right? Sometimes they have psychic symptoms, okay, or cognitive symptoms. It can be in the form of deja vu. They feel fearful, they feel anxious, altered perception. These are psychic symptoms, right? And most important is duration of this pre-ictal. For how long does it stay? Usually in seizures, it is seconds to minutes. Okay, that is all pre-ictal. Now, what happens in the ictal? In the ictal, you need to know what type of seizures is she having. Is it tonic? Is it clonic? Is it myoclonic? Is it atonic? Or is it just automatism? You need to know all this. Okay, so first thing is you need to know the motor signs. Okay, what happens? Is it tonic seizures? Is it clonic seizures? Is it tonic clonic seizures? Or is it just myoclonic seizures? Or it is atonic seizures? Or there is any automatism? Okay, automatism means any lip smacking, picking at clothes. Automatism is seen in case of temporal lobe epilepsy. Okay, so motor signs you will know. Then important, very, 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 very important question: consciousness. Is your consciousness fully preserved? Yes or no? Okay, so it is preserved in case of simple partial seizures or focal aware seizures. It is impaired in case of complex partial seizures, like one of the doctors told. I agree with that. Okay, so here, what about the consciousness? Did she lose her consciousness?
No.
No. Okay, fine. Then
Two
this
episodes
is
she showed. She said that 2 episodes she lost consciousness.
yes. She told she collapsed. She did not tell that she lost consciousness.
Okay.
Okay.
No.
Yes. So what was the duration? Usually this ictal phase it goes for seconds to minutes, which was the same case in even in our patient. Though nobody tried to explore it, that was a history. Post-ictal, you might go into confusion. You will have neurological signs in the form of confusion, drowsiness, headache. Sometimes it can be psychological symptoms like anxiety, irritability. Okay, and the duration. What would be the duration for post-ictal? It can be minutes to hours. Okay, in our patient, what do you think? Did she have in minutes to hours? She She told it takes 15 minutes to 30 minutes, isn't it, for it to be back to be normal. Okay, so among all this, how many symptoms did our patient have? None of you try to explore what her motor signs are. See, these are basics in history taking. See, these are the cases which will fail you your basis exam. You get ankylosing spondylitis, you will know your diagnosis. You get neurofibromatosis, you will know your diagnosis. Right? Those are easy cases. You have an acromegaly case in front of you, it's an easy diagnosis. You will know what to do. Right? With good online classes these days, everybody knows what things to answer and how to prepare. So you would have already prepared. It is these cases that will trick you, and that's where you will fail. You have to know what motor signs. You have to know what type of seizures is she having. Consciousness. You have to know. Okay, duration. These are very important, or else you will never know what's going on with the patient. I'll tell you the diagnosis, what's going on with this patient. Pre-ictal, none of you asked. Okay, none of you asked pre-ictal history here. Okay, even post-ictal, you were not concentrating on the duration. How long does it take for her to be back to be normal? Okay, so these are the few things that you missed. And now I'll tell you something. 50% of the patients who has seizures, okay, 50% of the patient who presents to you, even in your clinic, in your practice, in your hospital, 50% of the patients who is referred to you or you are seeing in the clinic or even in your ward, okay, do not have seizures. Simple. Okay, 50% of the patient do not have seizures. Then what are they having? So every two patient that is referred to you, simply they don't have seizures. They are presenting to you with seizures. So what do you think? What can be going on? What are the questions you will ask? What are the questions will you ask? See, there are few very important, even in your practice, trust me, from next time, if you start asking your patients, you will realize every patient you are seeing will not have seizures. Trust me. It's a very commonly misdiagnosed condition in the entire medical field. Seizures. They put a tag of seizures to the patient and they spoil the patient's life. Okay. Ask very specific, important questions. What are the specific, important questions? Anyone? Sweating. Before seizures, do you sweat? Before seizures, do you get any palpitations? Okay. Before seizures, any change in color? Do you look pale? Do you look white like a sheet or white like a ghost? Do you look gray? When she told you her husband has witnessed, this is the first thing you need to ask. Did your husband ever tell you that you looked very pale during these episodes? This is something anybody would have recognized because they go very pale. I'll tell you the reasons for all this. They go very pale. Did you change any color? Okay. Then, do you feel dizzy? Okay, when you're sitting, when you get up suddenly, or when you're lying down and you get up suddenly, do you feel dizzy? Okay, dizziness has to be ruled out. Okay, then is there any trigger for your seizures? Is there anything that triggers? How will you ask? If you ask your patient, do you have any triggers? You think your patient will answer you? No. What were you doing when you get the seizures? She told you she's sitting on table. She anticipates, isn't it? What was she doing before that? Did you go for a walk? Did you get out of your home, went out for a walk in a garden? Were you exercising? Was there any argument going on with your partner? Were you watching something on the television? You got anxious? Were you fearful? These are very important history. This is where your diagnosis is. You don't ask this question, you don't get your answers. If you had asked me this trigger, I'd have told you that whenever my husband shouts at me, I get this. And I also had a dizziness. When I'm lying down and I get up suddenly, I feel dizzy. Sometime out of nowhere, I start feeling dizzy. Okay. And triggers were when my husband gets angry at me, when he shouts at me, I get these episodes. Yes, I start sweating. I sweat before the episodes. Yes, I change my color. I look very pale. I look white like a ghost. Sometimes I even had palpitations. This was the history your patient had. So what's going on with your patient? You think this is seizures? When the patient has this history, you think this is seizures? Answer is no. This is not seizures. This is vascular problem. This is a problem with the heart. This is nothing but vasovagal syncope. That's all. That's your diagnosis. Trust me, once you start applying this even in your practice, you will see every patient that is referred to you, every patient that is referred to you will not have seizures. They have been simply misdiagnosed. And the same thing had happened even to our patient. She was unnecessarily put on all these stupid medications. She had a miscarriage, which had a significant in problem with her stress, with a family. She had various family issues because of that, because she could not conceive. And it had a psychological impact on her emotional well-being. It had an impact on her family, even with the relationship with her husband. And she had a lot of complications as a side effect of these medications, which was not required. See, though our medical field is so advanced, so it is so advanced, no modern MRI scan, no advanced technology will never ever replace the art of history taking. So what we needed for her to diagnose that she doesn't have seizures, just the history. That's all, just history. In history, 5 proper questions, you would know what's going on with your patient, right? So you make a significant difference in your patient when you're practicing in a right way. Unfortunately, nobody teaches this in the medical field, and nowhere anybody teaches this. So these are very important to understand. Okay, can make a huge difference in patient's life. What we did is we just stopped her medications and we sent her home, and she's all right. She had a vasovagal syncope. She was referred to cardiologist, and we ruled out any cardiac condition. We did an ECG, we did an echo, and she had a postural hypotension on examination, and she was sent back and with a proper counseling regarding the avoiding of the trigger for the vasovagal syncope. Now she is happy. She is planning to start family. She is out of all these medications. Right. So this is the difference you can do to your patients. Okay. Now I'll just brief you about the vasovagal syncope. Quickly, we'll finish the class. Okay. And I'll hand over to Dr. Harsh, who is going to take over. So what are the causes of syncope? What is syncope?
Esophageal.
Yes. So syncope is nothing but your, what happens is there is a inadequate blood flow to your brain. So temporarily the blood flow to the brain is reduced. Okay. So what happens? You will go in loss of consciousness, which is a reversible cause. Okay. Two important characteristics of syncope is it is always of very short duration, and there's a spontaneous recovery. Okay, there's a spontaneous recovery, which is very important to understand, which might not be there in the seizures. So when it comes to transient loss of consciousness, we have non-traumatic causes, you have traumatic causes. In non-traumatic causes, you have got syncope. Okay, syncope is a non-traumatic cause of loss of consciousness. The other causes of loss of consciousness, one is your epilepsy, which you ruled out with the seizures. One more is psychogenic, which you can again rule out with the history. Subclavian Steele syndrome, again, how you can rule out subclavian Steele syndrome? What do you do in subclavian Steele syndrome? How do you know?
Elevated the head or working by the hand before the attack.
Okay. Anyone else?
Unequal pulse.
So these patients will have arm claudications. Sometimes they can be neurological symptoms in the form of visual disturbances of ataxia, but they'll have fatigue, pain, or cramping pain, especially when their arms are extended. And there will be blood pressure differences between the both arms. Okay. And the radial pulse will be very weak. And if you auscultate, you can hear the bruit or the subclavian artery. Okay. And you do this ultrasound Doppler to rule out the subclavian Steele syndrome. Well, okay, so these are the 4 causes for transient loss of consciousness. So here our patient had the syncope, isn't it? So in syncope, what is one is your vasovagal syncope, which can be orthostatic, which can be emotional. So our patient had an emotional trigger. Our patient had situational syncope. Okay, and other causes are your orthostatic hypotension, autonomic nervous system involvement, like in a Parkinson disease or old age patients, or secondary autonomic failure, like in diabetes, amyloidosis, spinal cord injuries, or it can be simply drug induced, like your vasodilators, diuretics, antidepressants. Okay, or it can be because of volume depletion, like any bleed, vomiting, or diarrhea. Okay, so that is your orthostatic hypotension. So syncopal attack happens when you have low blood. Okay, or it can be vasovagal syncope, again, which can be again orthostatic and emotional. So our patient had a vasovagal syncope since 10 years and not seizures. Okay, even a syncope patient, once they get this collapse episodes, you take them and do an EEG, it will pick up some activities, but they are not seizures. Okay, and even a patient who is having seizures, if you do an EEG, it can come out to be normal sometime. Okay, so EEG is not a very specific tool. Sometimes it can be misleading. Just because EEG showed some waves, you cannot start the patient on anti-epileptics until and unless, based on the history, you are convinced that it is a seizures. See, everything is in the story of the patient, how they present, triggers, what happened. There was a stress trigger, isn't it? When the war broke out in her country, that would have been an emotional trauma to her. That's when all the symptoms started. See, that's why you have to know the onset, what happened around that event to start all the symptoms. Okay, so the history is very important. Then other causes are, it can be your cardiac related. That's why you need to rule out any arrhythmias by doing EEG. They can be structural heart defects. You can do a echo to rule out that. Okay, so this is very short information on the syncope and how do you approach that. And again, this important history taking. Okay, so we'll stop here. I will hand over it to Dr. Harsha now. There are a lot of images and videos that he's going to share with you now, and you're going to tell the diagnosis, and briefly Dr. Harsha will discuss you about the investigation and the treatment. Okay, and I welcome you to Astroset Academy, Doctor. Thank you for bringing your amazing videos and trying to help our candidates. I know you have put a lot of effort to gather all these amazing videos with the proper patient consent, and you have done an amazing job in your medical education till now with good followers on the Instagram, and very thankful that you agreed to come and help our candidates. Okay, right. I'll hand over the session to you, Doctor, now.
Hi, hello everyone. This is Dr. Harsh, and are you getting my voice? Is the screen visible?
Yes, sir.
Okay, great. So basically, I created Diagnosit, and it is a very good medical educational platform with more than 5 lakh learners worldwide. And I have worked with I have posted more than 4,000 clinical cases in that. And with that, there is a lot of clinical explanation to that also. So you can visit that and learn from those cases also. So today what we are going to do is, I'll be presenting some clinical cases. These will be like some clinical videos and some photos. And from that, you'll be asked to make a diagnosis. And then I'll tell you the diagnosis and some important points regarding that. So let's start the session. So this is a 52-year-old male patient who post total thyroidectomy, which was done for multinodular goiter, and presented to us with the findings of this perioral tingling and numbness. And when you can see the BP is being recorded of this patient, the characteristic hand movement of this patient. So this is the flexion at the wrist joint, and there is hyperflexion at metacarpophalangeal joint, and in extension at the interphalangeal joint. So what is this sign called, and what is the diagnosis of this case, and what can we do for that? Yes, you all are very right. This is a case of hypocalcemia. So what we should do for that, and what is the sign called? Yes. You all are absolutely right. This is a case of hypocalcemia caused due to this post-surgical hypocalcemia. This is a temporary hypoparathyroidism that usually occurs. There are many reasons for that. Like there can be injury to the parathyroid glands also. There can be injury or temporary vasospasm of the inferior thyroid artery that supplies the parathyroid gland. So that leads to hypocalcemia. And why this? Why due to this? When the BP is, can we make the slides bigger and speaker smaller? Okay, so you can just pinch out that screen. It will make it bigger. So yeah. So why this hypocalcemia makes this specific kind of hand movement of this patient? When the BP increases, there is like due to hypocalcemia, there is temporary ischemia. When the BP increases, there is temporary ischemia that leads to neuromuscular hyperexcitability and this specific sign. And there are other signs of hypocalcemia also, like the Chvostek sign and Trousseau sign. And other features of hypocalcemia, as you can see in this patient, this perioral tingling and numbness, and there is paresthesia of hands and feet, muscle cramps, and laryngospasm can also occur. And in ECG, we can get a prolonged QT interval. And investigations, like we can get decreased ionic and total calcium. How do you manage this patient? This is, I think, this will be asked to you. For an emergency case, we give IV calcium gluconate, and it is given in 10% concentration, and 10 to 20 ml is given IV over 10 minutes. If that gets corrected, we can repeat it 2 times, and then we start the patient on continuous calcium infusion. And there is one very specific clincher for that also. We have to check magnesium deficiency also, because that can also lead to similar kind of findings. Okay, so we are clear with this case. Now let's move on to the other one. So this 27-year-old male patient presented to us with severe pain in the bilateral arms and high-grade fever, along with restricted mobility and weakness in the bilateral arms. So you can see the size of biceps of this patient and the disproportionate size of the body as compared to the biceps. And there is a history that he is being injecting something in the muscles directly for muscle growth. So what can be the diagnosis of this case? You can mention it. You can comment it. Rhabdomyolysis. No, this is not. So firstly, let's discuss. No, this is not steroid myopathy. This is an abscess. What is the cause of that? What might this person be injecting? No, this is not steroid-induced myositis. Yes. This one is the right answer. Injection of oils directly into the muscle. This is a way the patient used this oils preparation. There are various preparations to increase the muscle mass. The most common one is steroids that causes the muscle hypertrophy. But in this case, the thing that is done is injection of oil directly into the muscles. It is synthol. It is called as synthol, SYNTH, synthol. And when these are injected in the muscles, they basically create some oil pockets and leads to foreign body, like there is foreign body granuloma formation and oil pocket formation in the muscles. And basically only the size of the muscle looks bigger, but it is not actually a big muscle. And the strength of the muscle basically decreases because of the fibrosis that is caused by this oil and this foreign body reaction. So why this patient is having this fever, high grade fever? Because due to like the bad practices of giving injection in the muscle, and due to very like aseptic condition, this leads to development of an abscess formation, myositis, and then again this leads to this kind of presentation of the patient, this high grade fever. And how do you investigate? We can get an MRI, and MRI can easily pick oil pockets and granulomas and abscess. And how do you manage it? Usually we need to give incision over these muscles to remove all the oil, and it has already turned into an abscess, completely pus. We need to evacuate all the pus from these abscesses, from these muscles. And it is a very bad presentation. If you see it, you'll never forget it. So IV antibiotics and incision and drainage is the management of these patients. So I think we are pretty clear with this case also. Let's move on to the another one. Is my speed okay?
Yes, sir.
Okay, great. So now let's discuss this case. So this is a 48-year-old chronic alcoholic male patient. So this is an alcoholic patient. This is a clincher. For the image-based questions, you need to just see some clinchers, and that these are like, if you like catch these clinchers, you are very easily going to score marks in these questions. These are very easy. Okay, so this is an alcoholic male patient presented with severe abdominal pain, fever, and shock. And along with, there is no history of trauma. Still, there is this blackish discoloration, and this is around the umbilicus over the flank region. You can clearly see. So, what is the diagnosis of this case? Yes, you guys are absolutely right. Yes, this is Gray Turner and Cullen sign seen in necrotizing pancreatitis. We can say that this is a hemorrhagic pancreatitis. So let's discuss this case and why it happens. It is very interesting. So everyone is clear with the diagnosis. This is a case of pancreatitis, and in pancreatitis what happens is, this is a very large topic, we need a very long time to discuss it. And in pancreatitis what happens is, enzymes are released in the circulation, and pancreas release what enzymes, like to digest everything. It can digest fat, it can digest protein, and carbohydrates also. So there is this elastase enzyme, there is lipase enzyme that leads to digestion of fats, and elastase may lead to digestion of the vessel wall. And when the vessel wall get dilated, there is hemorrhage, and you can clearly, there is a lot of fat around the around the abdominal region. So at the anterior abdominal wall, when the fat get lysed and the blood vessels are corroded, this leads to hemorrhage in this specific location. And when this occurs in around the umbilical region, this is called as Cullen sign. And when it occurs in the flank region, this is called as Gray Turner sign. And there is Fox sign when it occurs in scrotum. And okay, so what is the how to make the diagnosis. This we do serum amylase and lipase. We need 3 out of 2 things, pain, serum amylase, lipase levels, and radiological investigations to confirm that. How do we manage it? It is still a very big topic. The main thing is, we need to give fluids, and we need to stop the conversion of interstitial type of pancreatitis to a necrotizing one. And we can decrease a whole lot of complications with that also. And this definitely needs ICU management. Okay, everyone is clear with that case also. Now let's move on to the next one. This is very interesting, and I know you. Let's see how many of you know this. You can clearly see there are multiple round and uniform, smooth, radiopaque, air-filled balls in the thorax. You can clearly see. What are these balls? The name is written here, and the patient is a 57-year-old male with recurrent episodes of pneumonia, and patient had TB previously, and he was treated with some unknown surgery. So what are these? And no, this is not post-lobectomy. Staph pneumonia, yes, can be staph pneumonia. It can be done. No, it is not a case of diaphragmatic hernia. Fungal balls, fungal infection can be there, but these are not fungal balls. Plumbage, this is a right answer. So let's discuss it. So before the advent of these anti-tubercular therapy, before the 1930 to 1950, tuberculosis was very prevalent, and anti-tubercular ATT was not there. So there were many different historical treatments of tuberculosis. If you read it, these are very interesting. And so what people do is, like, tuberculosis mostly affects the upper lobe of the lungs. So what they do is, they put these lead balls, lucite, PB, plumbage balls. PB is for lead. So these they place these lead balls to compress the upper lobe of the lung. And when due to the chronic compression of the upper lobe of the lung get this tuberculosis gets, they think that this will get treated, this will get cured, and due to the damage to the upper lobe of the lung. But what happens after 1950s? ATT came, and we are very successful in treating tuberculosis, especially the drug sensitive one. But what happens is, these balls start leaking the fluid which is present inside them. There is a half-life to everything, right? So the fluid inside them starts leaking, and this leads to development of pneumonia. And these are also the site of colonization for various bacteria and fungus, and that also leads to development of pneumonia. Other pleural complications and parenchymal complications of lung, like bronchopleural fistula, empyema, and sometimes these balls get migrated and may come outside the thoracic cavity also. So this is a CT scan. This is enough for diagnosis of this case. And how do you treat it? We definitely, for any septic condition, the main treatment is, we need to remove the source. And for the source removal, the thing is, we need to remove these lucite and plumbage balls. Okay, so definitely, depending on the culture sensitivity, we need to give the antibiotic or antifungal treatment to the patient. Okay, so now let's go to another interesting case. So I'm playing the video. So this patient, after a road traffic accident, presented with difficulty in breathing And you can clearly see this is an ECG of this patient, very characteristic finding, and this is an echo image of this patient. So what do you think? What is the diagnosis of this case? This is a tamponade. Yes, yes, yes. You guys are absolutely right. So today let's discuss why this occurs. And in the ECG, you can clearly see there are low voltage QRS complexes. Along with there is alteration. This is called as pulsus alterance. There is beat to beat variability of the QRS complexes here. And one is small, one is large, one is another, again one is small, then large. So why it occurs? So you can see. Let's play this video again. You can clearly see the heart is basically swinging inside the pericardial cavity. So that is the main reason why we are getting this electrical alterance. When the heart is close to the lead which is catching the electrical activity, the QRS complexes is in larger size, and when it is away from that, it is in smaller size. And this is the actual reason why electrical alterance occurs. So it is a very straightforward diagnosis, like why this patient developed this post-road traffic accident, that why this patient developed pericardial tamponade. And so how do you treat it? There is one more thing. There is Beck's triad. So what are the components of the Beck's triad for this pericardial tamponade? There are 3 things in that. You can comment it. You need to catch these clinchers to answer the diagnosis and to diagnose the case actually. Anyone? Okay. Okay, I'm getting yes. You guys are absolutely right. There is hypotension, there is muffled heart sound, and the next one is there is distended veins of the neck. So this is these 3. Decrease there is hypotension, there is muffled heart sound, and there is dilated veins. Yes, this is the classical Beck's triad. And ECG, we can get some hint to the diagnosis of this case, and echo is confirmatory in diagnosing it. How do you manage it? For an immediate treatment, there is emergency pericardiocentesis, or we can directly put from the Ziffy sternum root, we can directly put a cannula and we can drain some amount of fluid. Even a very, very small amount of blood removed will give a huge relief to the patient. And there is emergency thoracotomy. There is indication of that also if the patient is not improving. So this is another interesting case. Now come to the other one. Okay. So the 60-year-old female patient presented to this sudden onset of heaviness of tongue and difficulty in speaking. You can clearly see the patient is protruding the tongue and it is deviating to the right side. So what is the diagnosis of this case? And definitely mention which side. The side is important in this case. This is a stroke. This can be a case of stroke. Yes, this is a 12th nerve palsy. No, this is not chorea. And this is medial medullary syndrome. Can be. This is a right side palsy. Yes, you guys are absolutely right. So the diagnosis of this case is hypoglossal nerve palsy, 12th nerve, hypoglossal nerve palsy. So why this happens? The definitive, you can say, like in this 60-year-old old age patient, the definitely there is like stroke is definitely in the picture. So this is a case of stroke. But let's discuss the important thing is which side. Like there are 2 kind of palsy, UMN palsy, and there is a lower motor neuron palsy. And in LMN palsy, what happens is there is this genioglossus muscle. When we protrude the tongue, there are 2 genioglossus muscles, and both pushes the tongue anteriorly and towards the opposite side. If there is weakness of one side of the muscle, like if there is right side of palsy, then there is weakness of the right side, then the left one pushes it towards that side. So in the LMN ones, and in the UMN, it is completely opposite due to the crisscross orientation. Okay. To diagnose the stroke, we definitely need an MRI. And then treatment, I think you guys must be knowing more than me. Okay, now let's come to the next case. So this is a 16-year-old aspiring young athlete patient, and this patient, after a very huge intense practice, presented with this kind of presentation. So what is it? And what electrolyte abnormality should we definitely think in this patient? Which electrolyte it is, which one is most important here? This is a fasciculation, cramps. Okay. Yes, you are right. Hypokalemia, muscle spasm, hypokalemia, potassium. Yes, you guys are absolutely right. So this is a case of hypokalemia causing the muscle spasm. So why hypokalemia occurred in this patient? This is aspiring young athlete. Due to overexertion, electrolyte disbalance occurred. Due to oversweating, due to oversweating, there is electrolyte disbalance, and the most common one we should think of is potassium. Potassium is very important. What are other electrolytes that can cause these kind of presentation? There is magnesium, calcium also. Now, and what other things like apart from electrolyte disbalance can this occur? Can this presentation be of? There is one exertional compartment syndrome also, and there is exertional rhabdomyolysis also, but the presentation will vary. Like they will not present immediately. Rhabdomyolysis presents after some time, and exertional compartment syndrome can present, but the fasciculations will be different. But the first thing you should definitely think of is hypokalemia, because this is a most treatable one. Okay, so this is a hypokalemia. Now let's come to the next case. So this is a 50-year-old male patient presented to us with this specific clinical finding. So what is this? When we are pressing on some bony prominence, in this case, we are doing it on the medial malleolus, just on the medial malleolus, and there is pitting edema. Pitting stays. So this is a case of pitting edema. So what are the causes of pitting edema? These things must be asked in your exams. Yeah, there are various causes. Like the first one is cardiac causes due to congestive heart failure. There is constrictive pericarditis. There is pulmonary hypertension with RV failure. And then there is renal causes like nephrotic syndrome due to hypoalbuminemia. Nephrotic syndrome causing hypoalbuminemia. And there is AKI and CKD causing salt and water retention. There is glomerulonephritis. And in the hepatic causes, there can be cirrhosis. Due to that, cirrhosis also leads to decreased albumin formation. And there are nutritional causes like kwashiorkor. And there is chronic alcoholism that also leads to development of hypoalbuminemia due to cirrhosis and liver dysfunction. There are endocrine causes like hypothyroidism and some medications like NSAIDs, steroids, and pioglitazone. And there is this venous insufficiency. In venous insufficiency also, there is edema of the lower limb. Okay. The next one is post-thrombotic syndrome, and there is this lymphatics. Yeah, lymphatic usually causes a non-pitting type of edema, but in the earlier cases, there is pitting also. Okay. Filariasis also, there is a pitting edema in the earlier cases. Later, it just convert to a non-pitting type. Got it? Now let's go to the another case. Okay. So this patient presented to our OPD. This is a 48-year-old male patient with this bilateral reducible inguinal swelling. And when we are asking the patient to cough, you can clearly see there is a bulge at these places. So what is the diagnosis of this case? This characteristic bulge at this position. So what is it? Answers, guys. Yes, this is an inguinal hernia. This is a reducible inguinal hernia, and with due time, when you examine lot of patients, you can like appreciate this is a direct one or indirect one also. So, but for you, this is basically a bilateral inguinal hernia. So, why the cough impulse occurs? You guys must know that there is a pressure when we ask the patient to cough. There is an intra-abdominal pressure that leads to hernia to displace outside of this opening that is already present there. So that leads to cough impulse, and cough impulse is better seen than palpated. So when the cough impulse is absent, in case of obstructed hernia and strangulated one, there is absence of cough impulse. And in case of obstructed hernia and the strangulated hernia, this is a surgical emergency. Okay, so this is a classic case of bilateral inguinal hernia, cough impulse present. Okay, so this is another very interesting case. So this 42-year-old diabetic male patient, look, another clincher. This is a diabetic patient now presented to us with the findings of right upper quadrant pain, fever along with chills. Okay, and in the CT you can clearly see there is abscess. There is these hypodense lesions. This is a clear-cut case of liver abscess. But the things get interesting here. So what happens is there is a right eye pain along with redness, along with decrease in vision. So which type of liver abscess do you think can lead to this decrease in vision and development of this eye signs? So what do you think? There is a specific bacteria. You need to name that. TB, no. Anything else? Any other? Hydrated, no. This is a liver abscess. Toxoplasma, no. This is very common one. Amoebiasis, no. Amoebiasis, no. This is a case of liver abscess. Strongyloides. Klebsiella, yes, this one is right. This Klebsiella. So what happens is, in case of diabetic patients, when there is Klebsiella related liver abscess, then the Klebsiella can travel to eye and may lead to development of endophthalmitis. There is a very Klebsiella tends to involve eye, and the eye involvement signs are pain, redness, photophobia, and there is decrease in vision, and this is an emergency, and this needs intravitreal antibiotics to treat it. Okay, so we need to intervene very early. For the liver abscess, we need to give antibiotics, and we need to drain the liver abscess if that doesn't treat it. Basically, in pyogenic abscess, we need to drain it, and in the amoebic abscess, we can try some medical management before draining it. But the thing is here is we have right eye involvement, and for that we definitely need an emergency surgical management, and we need to drain the abscess, and we need to give intravitreal antibiotics. Okay, so this is a very interesting case. So remember, this is a Klebsiella. Okay. Okay. The next case is, what is this lymph node called? Can you see there is this lymph node enlarged here? What is this side? Oh, sorry. What is this side? This is left side. Left side lymphadenopathy. So what is this? This is a Virchow's node. Okay. No, this is not systematic Joseph. This is left supraclavicular node. Virchow's, GI malignancy, Virchow's, you guys know everything. Okay. So the diagnosis of this case is Virchow's node. And this is the left supraclavicular lymph node. So why left? Why not right? What is so important here that the GI malignancies tend to drain to the left side, not on the right side of the node? Drainage, yes. Drainage of what? Thoracic duct. So thoracic duct drains where? This is a very classic question that is asked. Lymph system, gastric carcinoma. Gastric carcinoma is the most common one. So thoracic duct drains in IJV, left side IJV, and left side of subclavian vein. Junction of these two, the thoracic duct drains. So this leads to what happens is there are tumor emboli from the GI malignancies and some intra-abdominal malignancies. They go towards the heart via the thoracic duct, and there is some kind of distal blockage to the thoracic duct due to these tumor emboli, and there is retrograde flow of lymphatics, and this is the place where there is the turn of the thoracic duct where it tends to drain. So this is the place where maximum tumor emboli get rested. So that is why the Virchow's node, or we can say Trousseau sign, occurs. Left supraclavicular lymph node enlarges. Okay, this is not azygous. This is thoracic duct. So the causes, there are intra-abdominal malignancies like gastric carcinoma, pancreatic cancer, gallbladder cancer, and one more thing. This is a sign of inoperability. If there is this Virchow's node present, the sign of inoperability, we can't operate that patient. Okay. There are various malignancies: testicular cancer, RCC, and ovarian cancer, and prostatic cancers, lymphoma also. We reach to this lymph node. Okay. Now let's move to the another case. This is very interesting. See. This baby is held in ventral suspension position, and this examiner is can't see the screen. What happened? Wait. Are you getting the screen now? Okay. So let's restart it from this case. So what this baby is held in upside down position. This is in like this ventral suspension position, and you guys are able to see the video, right? Okay. So this is held in ventral suspension position, and the examiner is stroking on one side of the back of this baby. So you can clearly see this movement of the baby. What is this reflex called? What is this sign called? And what is the significance of it? Let's see. Answer it in the comment section, this inbox. Do you know what is this reflex called? No answer. I think this is a difficult question. This is a case of this reflex is called as gallant reflex or incurvation reflex. So what is happening here is this is the usual way of eliciting this reflex is hang the baby upside down in the ventral suspension position and just stroke one side of the body, and the back of the baby turns towards that side. Okay. So this is why the reflex is elicited. The normal age by this 4 to 6 months of presentation, the normal age, like this usually disappears by 4 to 6 months. Timing is essential. Na? You need to remember it. If it persists beyond that, there is something abnormal. There is some upper motor neuron disease. Most probably there is some, like in cases of CP, cerebral palsy also. And like there is one more abnormal thing about it. If the one side if we stroke it on the one side and the baby doesn't move towards that side, but the moves towards the opposite side, so there is this case of like unilateral spinal lesion. So we need to know about that also, and the timing is 4 to 6 months. Persistent beyond that is abnormal, and if there is this unilateral reflex present, then that is abnormal. Okay, so this is a gallant or incurvation reflex. Okay, now this another interesting case. Can you see the presentation of this baby? How the baby is like holding this specific posture. So the important thing is this baby was frank breech presentation and born by the vaginal delivery. So what happened is, anyone want to name this condition? This is called as packaging deformity. Packaging deformity. So what happens is, due to like soft tissues of the hip region, like adapts to this kind of intrauterine position. But there is nothing to worry about. This usually gets corrected with time, lasts for around 2 to 6 weeks maximally, and usually gets corrected after that. But what is important is we need to differentiate it from DDH. What is DDH? DDH is developmental dysplasia of hip. So we need to differentiate it from that, and there is no need to worry about. Just counsel the patients that counsel the parents of this baby that this will resolve on its own. Okay. So this is a very, very interesting case. Another one. So this newborn baby is presenting with this kind of sign. This is important for you all. What is this sign called? And why it is present in this baby? Until what age the presentation of this sign is considered normal? Yes, this is Babinski sign. We need to we can stroke the lateral side of the foot, and there is dorsiflexion of big toe and the fanning of other small toes. Okay. So usually what is written is it is present 12 to 18 months. If it is present till 12 to 18 months, it is considered normal. And if it is present after that, then it is considered abnormal. Why it is present before that is normal? Because of myelination. Myelination is usually not complete at birth, and it usually gets completed with time. And the corticospinal tracts get myelinated till 18 months. And if it is present beyond 2 years, this is definitely considered something abnormal. Okay. So this is a case of Babinski sign, normal Babinski sign. Another case. Can you see the eyes of this baby? The eyeballs are larger than the usual, and the parents notice that the size of the eyeball is less. Size of the eyeball is more. It was lesser at the time of birth, and now it is like increasing. That is not normal, right? So what is this called? Myopic eye. Anything else? This is called as book-thalmos. Okay. So what happens is, like there is this glaucoma in the baby. So what happens is, in the eye of the baby, like these are more elastic, and cornea and sclera are able to enlarge in size. Na? They are able to increase in size, and due to increase in intraocular pressure, the size of the eyeball as well as sclera and cornea increases, and that leads to development of this specific condition in the baby. This is called as ophthalmos. Okay. So what other signs are we going to see in these kind of patients? One is enlarged globe, enlarged cornea. There is photophobia. There is blepharospasm. There is excessive lacrimation, and the photophobia. That this is usual. Okay. So how do you what do you do in these cases? Like we need to check the intraocular pressure, and we need some things to decrease that pressure. And these might also need surgical correction also. Okay. So goniotomy is the condition. The goniotomy is the surgery which is done. Okay. The medical treatment is topical beta blockers. Okay, that decreases the pressure, and there are other drugs also. Another pediatric case. So what is this? This is a very spot clincher diagnosis. What is this? This is asked in usually every exam, all the exams. What is this called? Meningococcemia, meningococcal sepsis, purpural fulminans. Mastocytosis. These, these are differential diagnosis for that. The diagnosis is this rubella. Yes, this is the right answer. This is called as blueberry muffin rash. Okay, so the important thing is this can occur in all the torch infection, but the most common one is rubella. It is the most important one. So why this occurs? The important thing is why it occurs. So what happens in congenital rubella or torch infection? What happens is there is some like this when there is this rubella infection, there is interference in the this hematopoietic mechanism. There is bone marrow, like at the normal places, the bone marrow gets suppressed, and there is shifting of bone marrow from the normal places, like bone marrow, and from the bones, from the liver, and from the spleen. Like this gets shifted to the dermis and skin and get deposited there. So this leads to development of these kind of small nodules, and looks like the blueberry muffin. So that is why this is called as blueberry muffin rash. So you need to remember what are the types of torch infection, and this is the specific rash. This can be asked. Okay. So yes, this one is another pediatric case. You can clearly see there is bilateral breast enlargement of this baby. See, this is a one-day newborn baby. How is this possible? What is the diagnosis of this case? Is it normal? Yes, this is called as gynecomastia. You are right. Maternal prolactin transmission. Yes, one of the part. Kalman. This is the physiological gynecomastia. Okay, this is a physiological condition. Yes, what happens is due to transplacental maternal estrogen and progesterone that gets transmitted to the baby, and this leads to parenchymal and stromal proliferation of the breast and development of this kind of gynecomastia. Okay, so this is completely normal. Even some amount of milk secretion from these breast buds are also normal. This is called as witch's milk. Okay, so this is also normal, and it gets corrected in 2 to 6 weeks. But the important thing is we need to differentiate it from mastitis or breast abscess. Like if mastitis or abscess develops, what happens is we need to give antibiotics to the baby, and in some cases we need to drain it also. Okay. Yes, you're right. This is witch's milk. Okay. Now another pediatric case. So this 3-year-old boy presented with loss of appetite and pot belly, and there is irritability and brittle scalp hairs, and you can clearly see there is this pot abdomen, and this baby is 3-year-old, and there is loss of appetite, pot belly. So what is the diagnosis of this? Yes, this is a protein energy malnutrition. This is severe acute malnutrition. This is a typical case of kwashiorkor. Okay, this is not marasmus. This is kwashiorkor. There is pot belly. So what happens in these cases is there is inadequate protein intake, but there is some amount of calorie intake. The baby is usually 6 months to 3 years, and there is this development of hypoalbuminemia. Protein is less. Decreased albumin or decreased protein leads to hypoalbuminemia, and then development of this kind of ascites, and then pot belly. And there is basically you can clearly see the dilated veins over the abdominal wall also. Okay, some other signs are edema, dermatosis. The name to the dermatosis is flaky paint. Flaky paint dermatosis. There is hepatomegaly due to fatty infiltration. There is growth retardation, which is very common, appreciable, and there is apathy, irritability, and brittle hairs, scalp hair changes. And the sign for these is called as flag sign. Okay. So the treatment is we need to like gradually increase the nutrition of the patient. We can't give it like a very large amount of nutrition at one time. So what happens is there is development of refeeding syndrome. So we need to prevent that also. So that is why we need to gradually increase the nutrition part. What is the hallmark of refeeding syndrome? The main electrolyte that we see in that refeeding syndrome, the phosphate. Good. You guys are right. The phosphate is most important one. Other things are also decreasing, but the phosphate is what is important to make the diagnosis. Okay. So let's move to the next one. Oh, the video is working. Okay, let's discuss this. This is a very interesting video. Look, this patient is able to approximate both of his shoulders anteriorly, and there is something absent here. So what is it? What is the diagnosis of this case, and what other findings we can appreciate? Okay, I need to stop this video. Okay. Yes, this is cleidocranial dysplasia. This is not EDS. First rib abs? No, first rib is present. See, first ribs are present. So what is this? This is a case of cleidocranial dysplasia. Okay, so what happens is there is this RUNX2 gene mutation on the chromosome number 6, and this RUNX2 gene is basically important for intramembranous ossification of the bone. And what bones get ossified by intramembranous way? These are the clavicles and skull bones and teeth. Okay, so the main defect here is there is absence or hypoplasia of clavicle. Like you can clearly see, there is no clavicle here. Okay, so clavicle is absent. There are skull bones defect, like there can be facial frontal bosing, there can be vermian bones in the baby, and there can be teeth abnormalities. So what teeth abnormalities? Like there is exfoliation of the teeth, there are supranumerary teeth, and there can be malocclusion also. Okay, so there are other skeletal abnormalities, like the child can have a short stature, there can be a wide pubic symphysis, and there can be coxa vara. Okay, so what do you need for the diagnosis? One is this characteristic history and this absence of clavicle or hypoplasia of clavicle, and other is you can also go for the testing of this RUNX2 gene on the chromosome number 6. And for the management part, the patient might need various surgeries, like oral and facial surgeries to get the correction of the facial appearance of the baby. And so who was the, like there is a character in Stranger Things who has this cleidocranial dysplasia? Okay, let's move on to the next part. Okay, so you can see these are painless lesions, and these are very small vesicles. Wait. These are very small vesicles along with central umbilication. Okay, so this is a very characteristic sign. This is a very characteristic image. So what is the diagnosis of the? Oh, you guys wrote it. This is a case of molluscum contagiosum. This is a viral disease. So what is the virus that causes this disease? Name of that, and basically the family of that virus. Name is, this is present in the diagnosis of this case. What is the family of that virus? Yes, pox virus. This, you guys are absolutely right. So this is a molluscum contagiosum caused by pox virus. The mode of spread is skin to skin contact, and there is like this is skin to skin contact and some towel spread also. No? It can also occur in sexually transmitted disease also. And what can be the complication of this? There can be secondary bacterial infection in that. There can be like secondary eczema in these also. There can be like this is very like at the site of trauma these vesicles get developed. Yeah? So what is the treatment of these? There is no like such single treatment for it. There are various treatment like podophylotoxins, like imiquimod cream. There are some wart paints like contains some salicylic acid. Yeah, this, you are right. This is a supportive treatment. But for some warts, we can like if there is secondary infection, we can do, and we need to give some antibiotics also. Okay, but antibiotics are not the treatment of molluscum contagiosum. I'm not saying that. So this is molluscum contagiosum and supportive treatment and some imiquimod cream. Yeah, cautery can be done, cold cautery, and yeah, we can do like liquid nitrogen therapy also. Okay. Now the next case. Okay, this is very important for you guys. This is a 78-year-old male patient who presented with severe, painful, indurated plaques over the lower limb, and he's a non-diabetic, end-stage renal disease, hemodialysis. Not ecthyma gangrenosus, necrotizing, no. Calciphylaxis. This, yes, this is calciphylaxis. Yes, you guys are absolutely right. So this is a case of calciphylaxis, and it is very important to, like in the patients who are going for hemodialysis, the thing which should be monitored to prevent this dreaded complication is calcium phosphate ratio. Phosphate product, there is a product for that also. And so you need to like this should stay less than 70. So that this calciphylaxis does not occur. This is a very painful condition, and this basically marks like the disease is more advanced. Okay, so this is basically the calcification, and the calcium gets deposited at the like end arteries and end veins, and this leads to development of gangrene of this specific area. Like this calciphylaxis, there is a part of this calcification, and that calcification can be dystrophic, metastatic, and there is another classification for that also. Like calcification can be like in a specific area. It can be calciphylaxis circumscripta. It can be like universalis. There can be various permutation combination for that. But this is a case of calciphylaxis. And what is the treatment? We need to decrease the amount of calcium and phosphate. And there is supportive treatment. If there is gangrene, we need to debride that. We need to prevent secondary infection. We can give antibiotics. And for larger regions and for decreasing calcium, what we can do, we can give bisphosphonates. For the phosphate, we need to give phosphate binders. We need to start it early in the phase of dialysis, so that basically the treatment is prevention is best for this disease. Okay, yes, sevelamer is the phosphate binder, the most commonly used one. Okay, so this is an interesting case for you. Now let's come to the next one. Okay, this is a very interesting video. You can see this is pressing on some place and the swelling is disappearing. So this is a 44-year-old gentleman who presented to OPD with swelling, mild pain over the right forearm region, end-stage renal disease, and he's on maintenance hemodialysis. And what is this here? This is an AV fistula. Yes, this is an AV fistula. What is the most common AV fistula which is made? What is the name of that? It is a radiocephalic fistula between the radial artery and cephalic vein. The name is Kiminose fistula or Seminose fistula, what you guys call it. No? It is a Kiminose fistula. It is the most distal one. The proximal one that can be made are between the brachial artery and cephalic vein, brachial artery and basilic vein also. We can also use, like if the veins are not present, we can also use some grafts between the veins of grafts also, like Dacron. Okay, so there is some important timeline, like after the fistula, after we make the fistula, it takes around 6 to 12 weeks, not months, weeks to get functional. And the important thing is after 6 to 12 weeks, we are able to hear the Palpable. There is palpable thrill and audible bruit that is heard over the fistula. So what is the sign called? This is a specific sign in cases of fistula. This is called as Nicolidoni sign, something like that. Okay, so when we press on the feeding vessel, feeding artery, basically this leads to collapse of the swelling. So this is a very characteristic sign of AV fistula. Okay, so let's go to the next case. This is a very characteristic one. What is it? Bruit, you are right. This is case of clubbing. You guys must be knowing all the causes of clubbing. So what is the grading of the clubbing? There are how many grades of the clubbing? This is a Scamrod sign, Scamrod's window. Yes, there are 4 grades. In the first grade, there is this Scamrod sign is not lost in the first grade. Yes, in the first grade is there is only fluctuation of the nail bed. There is the Lowy bond angle is still maintained. From the second grade, the angle gets more obtuse. Yes, you are absolutely right. So there are 4 grades. The fourth one is hypertrophic osteoarthropathy. It is a painful clubbing. So there are various causes of clubbing. You guys must be knowing that. There can be pulmonary causes. Lung cancer, this is a case of, in lung cancer, we get painful clubbing, bronchiectasis, lung abscess, cystic fibrosis, cardiac causes like congenital heart diseases, cyanotic disease, and endocarditis, cirrhosis, IBD, thyrotoxicosis. There are different causes also. Okay, so now let's move to the other one. This is a case of clubbing. Okay. Yes, this is another interesting case. So this is a 43-year-old gentleman who presented to us with palpitation, arthralgia, and vomiting for 2 hours after the scuba diving. This is a clincher here. What is the diagnosis of this case? You can clearly make it just by this. And there is diffuse violaceous skin mottling over the tongue. You can clearly see this is the skin mottling. And in the CT scan, you can clearly see there is gas in the portal venous system. What is the diagnosis of this case? Yes, this is nitrogen, air embolism. Yes. Yes, you guys are right. Air embolism, air embolism. This is nitrogen embolism. Okay. So what is the name of this disease? Yes, this is Bent's disease. So what is it? What happens is, you guys, like during the preparation period, you guys must be knowing that there is this Henry's law, which states that when the pressure is high, then the solubility of the gas increases. So this is what happens when the scuba diver goes at a deeper plane, like deep in the sea. The pressure is very high and the nitrogen gets dissolved in the blood. And when this scuba divers comes up, as per the Henry's law, pressure decreases and the solubility also decreases. The gas comes up, and the solubility of the gas decreases and stays inside the body. And it and at which place at all the places where it goes, this leads to development of various kind of symptoms. And this is a typical case of this is a typical case of this decompression sickness or Bent's disease. There are various other names of this disease also. You must know that also. Okay, so there are 2 types of Bent's disease. One is type 1, which is very mild form, and the type 2 is severe one. Severe one has neurological symptoms like dizziness, seizures, and paralysis. There can be respiratory distress in severe ones also. The grade 1 is usually self-resolving and resolves without any complication further. But the grade 2 usually stays, and there must be usually some complications definitely occur in grade 2 stays. Okay, so how do you treat it? Firstly, how do you diagnose it? The diagnosis is pretty straightforward. The most common one is, the first thing that you should see is the clinical history of the patient. Next one is physical examination. Then you can go for Doppler, USG, or for MRI also. Okay, and how do you treat it? The main treatment is recompression therapy. Okay, recompression is a must. It is done in hyperbaric oxygen chamber. Okay, so basically we gradually takes the patient from a higher pressure towards the lower side. So that leads to these body basically adapts to that pressure, and slowly if we decrease the pressure, then the patient gets relieved. Okay, let's move to the next case. Yes. Okay, so this 45-year-old female patient, she presented to us on second day after elective cholecystectomy. and there is greenish discoloration of urine. So what is the diagnosis of this case? There is greenish discoloration of urine. Which drug causes greenish discoloration of urine? No, this is not bile. This is the catheter, urinary catheter. Yes, this is propofol. Yes, propofol. Propofol is the culprit here, and propofol causes the greenish discoloration of the urine. Which other drugs causes greenish discoloration of urine apart from propofol? Most common one is propofol. Other is there is amitriptyline, cimetidine, and indomethacin, and methylene blue also. Okay, there is this dye called methylene blue. Yes, you are absolutely right. Methylene blue dye. If we give the patient the methylene blue dye, this get absorbed by the intestine, and when get secreted, this specific blue green kind of coloration can occur in the patient. Okay, so the important thing is what is the compound that gives the color to this urine. This is a quinol compound. Okay, quinol gets this greenish color to the compound. Okay, you guys are absolutely right. There is no specific management needed for this condition, and one of the important thing is this is not at all associated with any case of renal failure. Okay, this is very common finding that we see in a post-operated patient. Okay, now another case with the different urine color to you. Yes, so this is a case of, you can see there is a purple colored urine bag. There is purple discoloration of urine bag, and patient had history of bilateral femur neck fracture and osteoporosis 1 year back, 79-year-old bedridden female patient, and there is chronic catheterization. Copper, UTI, yes, UTI is a cause. Basically, we need a spectrum of different conditions to come together to make this color of urine to like this purple color. So what are these conditions? This is a very interesting case. Anyone? UTI is one. One is constipation. The next one is catheterization, UTI basically. Okay, so what happens is due to constipation, there is, yes, there is a, these are indole compounds. You are absolutely right. So what happens is due to constipation, there are a lot of bacteria in the large bowel that basically degrades this the fecal matter and leads to development of indole compounds. And when these indole compounds get, yes, tryptophan diet is a cause. And when these indole compounds get absorbed via the circulation, via the portal vein goes into the liver, they get they get they get excreted, and with the bilirubin they get converted to indigo blue green color and indobilirubin compound, indorubin, which we call it. And when they get secreted by the urine, these are called this gives the specific color to the urine, and this is called as purple urine bag syndrome as per the name of the color of the urine bag. Very simple. Okay, okay, now another case. So see this chest x-ray. What is the diagnosis of this case? What are the findings you can appreciate here? There is hydropneumothorax. Okay. Is there is an ICD in situ? Can you see an ICD? Okay. Yes, there is no ICD here. This is a very typical case of hydropneumothorax. You can see pulmonary parenchyma and these bronchovascular markings are visible here. There is nothing here. There is characteristic air fluid level. Characteristic air fluid level present here. Okay. So this is a very typical case of hydropneumothorax. So how can hydropneumothorax develop? How can air and fluid both be in the pleural cavity? It can occur. Most common one is trauma. Okay. The most common cause is trauma. The other causes can be infective, like in tuberculosis, iatrogenic, like post-thoracocentesis, post-central insertion. So one thing can happen is central line can go directly into the pleural cavity, and someone accidentally connects the IV drip to that central line, and this may lead to development of pleural fluid. The pleural fluid may stay inside this pleural cavity, and development of hydropneumothorax can also occur. You know, So the characteristic finding, you all must be knowing that the characteristic finding of a hydropneumothorax. Okay, so what is the treatment of it? We need to insert an ICD tube. Okay, so where an ICD tube is inserted, it is inserted in the fifth intercostal space. Okay, in the triangle of safety. So what are the boundaries of triangle of safety? Where is it? Anteriorly, posteriorly? Basically, it is present in the lateral chest wall. Yes, base of apex of axilla. It is apex of axilla. Posteriorly, there is lateral border of latissimus dorsi. Anteriorly, there is lateral border of the pectoralis major, and on tip there is apex of axilla, and below there is fifth rib, and in the fifth intercostal space we insert this intercostal drainage ICD tube. Okay, so this is an important thing. Okay, now the another case. What is this? This 65-year-old female 65-year-old female presented to us with pleuritic chest pain on the left side along with fever and cough, and you can see what is this. And the important thing is, can you see there is this air fluid level here also? Above one there is air and below there is fluid. Yes, this is a case of lung abscess. Okay, and in the lung abscess there is a pus collection below, and above there is air. So this is a very characteristic finding which is seen in cases of lung abscess. Okay, so what are the causes of lung abscess? One is post aspiration in alcoholic patient, in elderly patient, in patients with GERD, in patients with poor dentition, poor oral hygiene, that due to aspiration may develop lung abscess. Hai? There can be post pneumonia, sequelae of post pneumonia. There can be some septic emboli like infection somewhere else, and the development of lung abscess like endocarditis. Okay, there can be some obstructed lesions like in cases of tumors or some foreign body. Okay, and it can also be a complication of TB. There can be an like hollow cavity formation by the tuberculosis, and that gets secondarily infected and development of lung abscess can occur. What are the other features, clinical features? The one is foul smelling sputum along with high grade fever and chest pain. This patient is having like that. Okay, so how do you treat it? The main treatment is IV antibiotics, and usually we do not need drainage, but if the patient is not improving with the IV antibiotics, then we might need to drain this abscess cavity also. Okay, so this is an important case for you all. Now another one. So this is a very important spot diagnosis. You can clearly see what is it. What is it? Both the hand and feet along with the part of the body. Can you see the screen right now? These are warts. Yes, you are right. Yes. So this is a case of epidermodysplasia verruciformis, or it is also called as Treman syndrome. So, so what do you need to know in this is there is EVER. These are the EVER1 and EVER2 gene mutation in this case. Yes, this is a Treman syndrome. The gene mutation is EVER1 and EVER2, and this makes the patient more prone to the HPV infection. And when there is a lot of HPV infection in the patient, this leads to development of these kind of verruciform lesions and appearance of tree bark like condition. So what do you do? So this patient have to, like after these lesions develop, there are various treatment options like the surgical remover. There can be debulking by of this hyperkeratosis. We can go for laser therapy, and retinoids and interferons are also helpful to decrease the keratosis of this patient. Okay, yeah, so this is another interesting case for you all. So this is a 55-year-old diabetic male patient who presented to us with ulcers. I think you guys are making the diagnosis. This is an aphthous ulcer. You guys are absolutely right. But what is important here is patient is having diabetes, started on clozapine 1 month back for the treatment of schizophrenia. Yes, you guys are absolutely right. This is a case of agranulocytosis. So what happens is you need to check for clinchers in this case also. Yes, this is a neutropenia, like the patient is having diabetes. The patient is having diabetes, clozapine is started, and clozapine is a risk factor for development of agranulocytosis. And what agranulocytosis means, the absolute neutrophil count decreases to less than 500, and this makes the patient more prone to development of various kind of infections. And for the infections, the most important ones, the earliest presentation can be just a fever, ulcers, or pain on speaking. So this leads to development of agranulocytosis. Okay, so important thing is so the important thing is, how do you manage this condition? You need to start. Firstly, you need to stop this clozapine. Okay. Then you need to start some other treatment, like you need to replace this clozapine with something else. Then you need to start broad spectrum IV antibiotics. Then you can go for filgrastim. If the absolute neutrophil count is less than 1000, then filgrastim is indicated in these patients. Okay. Okay. So I think we can finish it here. I have few more cases. What do you want? Do you want me to discuss it? We have discussed 30 cases. I think we can stop here. We can discuss remaining ones in the next part also. Dr. Rathore, I need you to take over. Hello.
Hello. Hello. Yes, doctor. Thank you.
Okay.
Thank
I
you
think
so much.
we have discussed all the 30 cases.
Yes, yes. That was an amazing discussion, doctor. Wonderful cases.
Thank you.
Right. Thank you for taking your time on this image-based discussion. Hopefully, we'll have one more session next weekend. I hope everyone
Sure.
enjoyed. You all can join our WhatsApp group, and you can kindly post your reviews in the group. All right.
You can
Thank
also
you.
reach me on my page on the Diagnose It. You can even search it on Instagram. It is visible on the top. Diagnose It. You can reach me over there. If you want to ask something from me directly, you can ask there also.
Yes, you can post your Insta ID in the group, doctor.
Yeah, sure.
All right. Right. Thank you. Thank you. Thank you, everyone.
Thank you very much.